Another interesting presentation that we saw was by Dr. Heather Wakely from Stanford, talking about a rather ill-fated third-generation EGFR inhibitor called ruxolitinib in a trial called Tiger-X. The interesting part of this was that although that agent is being discontinued, it certainly has activity in acquired resistance for EGFR mutation-positive patients, that is, progression after the first-line EGFR inhibitor. That's a setting where we see a particular activating or acquired resistance mutation called T790M in about 50 to 60% of patients. And this agent, ruxolitinib, as well as one that's now approved called osimertinib or Tagrisso, has good activity. And the challenge is in identifying these patients, and often getting a repeat biopsy at progression can be a barrier, particularly when tissue is required, and tissue is not always accessible because there may not be a large volume of disease, a good situation, but it may be inaccessible. So this presentation was about testing for T790M, this mutation that signals the potential or high chance of utility of Tagrisso if you have T790M, and looking for it in plasma and urine. So what she showed was that the sensitivity was in the range of 80–81% for both plasma and urine when it was matched with tissue that was available in the same patient. And they even picked up about the same number of patients as when tissue was done, and it included inadequate biopsies. What do you think of these data? Maybe, Everett, I'll start with you. And do you think that this is enough to impress you to use this? And if so, how would you use this? Would you just test plasma first? Would you even think about doing a combination because you can pick up more? And is it going to be your low-hanging fruit before pursuing tissue, or do we need more?
Jack, I think this is one of the most important presentations at ASCO, because if you think about what could make an impact on a patient's life, right, or the number of procedures that somebody has to go through to be able to do a liquid biopsy, a blood test, as opposed to needing to do a true biopsy, usually in the lung, with all the risks associated, is tremendous progress. So what I saw in the data was that plasma is a very, very good method to determine a mutation.
I'm sorry, could you explain what the plasma testing is?
Plasma testing means you do a blood test, and there is now methodology that allows to look for mutations in the blood, because the tumors shed a little bit of the DNA that is in the tumor, and these are tests that can detect that. Okay. And up to now, we've needed to do that from a biopsy that can now be done finding tiny, tiny particles of DNA in the plasma. And that can be done similarly, is my understanding, with multiplex, so they can look at multiple mutations, not just one. And it's for the first time actually conceivable that in a broader number of patients, you could, over a lifetime of that patient, on clinical trials or off clinical trials, look for mutations and guide your therapy not once, but repeatedly. So I think it's exceedingly important. Practically, I think it means you start with a plasma biopsy. You build up some confidence, and I think all of us have to do that because it's just emerging data. And then if that is negative, you probably still need to do a biopsy.
Right. I think that's also a key point of this, is that none of the approaches, plasma, urine, or tissue, was perfect. They each had a comparable miss rate, with tissue that could be just not getting the right part of the cancer, or just a failure rate of that too. So that you could potentially have a yield for doing one approach after another, that they are not mutually exclusive, and you can't conclude that somebody with a negative urine or plasma, or tissue for that matter, is just categorically negative. So.
Yeah, I have to admit, the idea that urine could be positive when tissue and plasma is not, which I think was the case if I saw the
It was,
is counterintuitive, but it is what the data show.
Yeah, I mean, it sounds like you'd still need to see it with your, to believe it, yeah. What do you think?
I would say that we have seen far more sets of evidence for plasma testing, And urine, we're beginning to see some data. I would say at this point, plasma, I feel a little more comfortable ordering it. Now, I think our patients should be aware of the fact that there are still a number of different technologies that are being used by various commercial entities. So if you're specifically looking for a gene like EGFR and you know what you're looking for, plasma testing is sufficiently good, but it's not in the same league as tissue testing when you're looking for a broad set of what is in your tumor. So that is a different limitation of plasma testing, but that is being addressed by some of these entities in the form of NGS testing. What I would say is right now, Tagrisso is only approved for use based on a tissue-based testing. So the payers may not pay for plasma-based testing in some parts of the country, so that's something we need to contend with. Hopefully that will change quickly with emergence of plasma as another companion that is approved by the FDA. So if you start with plasma, if it's positive, then you may be able to go to therapy with Tagrisso for T790. If it's negative, you would still need to go and get a tumor biopsy. What we don't want is patients and physicians assuming that if the plasma is negative, that the patient does not have T790.
Right.
Although this is still very exciting for patients, we've been waiting for a long time to get some evidence that doctors would accept that this liquid biopsies worked. So this is really cool.
Yeah.
Right.
I get the sense that there's not going to be a high burden of proof required, that this is something that patients are going to be extremely receptive to.
Yes, I'd much rather get a blood draw than go through another bronchoscopy.
Yeah,
It's
understand.
great technology.
Yeah.
It's really
And I think it is exciting to think this is not the end of the story, that we're just really beginning to learn, and the technology has only been getting better rather rapidly. So the thought may be that this is going to broaden the opportunity to do much more molecular oncology for a broader population less invasively.
I also like that the urine testing was included because you can't do blood draws on every single day all the time, but you know, people go to the bathroom a lot.
Yeah. So, I mean, that was another interesting correlate of this, some very early work just showing a proof of principle that in a few patients, this was single digits, that the urine test T790M quantitatively going down was predictive of a good clinical and radiographic response. That said, a lot of my patients tell me their cough or their chest pain was getting better within a week, and I'm not sure if you need the urine test to tell you that as patients are feeling better. But it is provocative that you could use this between scans or help modulate how frequently you need to do scans when you see that other parameters are getting better.
Well, it could also be reassuring because frequently those of us with lung cancer do tend to get pneumonia or a chest infection, and you never know whether that cough is just the virus that's going around or your cancer's coming back. It would be reassuring to be able to just have a blood test and say, nope, you're good.